All right, everyone, so I would like you to imagine that you have just been discharged from the hospital after a pretty nasty bloodstream infection. When you came in, we had to intubate you. You were pretty septic. You couldn't oxygenate very well. You got about 3 rounds of epinephrine, 4 rounds of chest compressions because you coded on us. You have a couple cracked ribs. We are sorry about that, but those will heal. Your infection got so bad that it actually seeded to your heart, and we had to remove one of your heart valves, and that was pretty awful. But nevertheless, we're discharging you home. We're giving you about 6 weeks of IV antibiotics. Don't worry about that. You are out of the ICU, and you can be comforted that you are back at home. Now, what if I told you, for everyone in this room with that scenario, about 20% of you would readmit back into the hospital within 60 days of that initial discharge? Are you comforted? Probably not. But that is the current outlook for all patients that we send home today on IV antibiotics. In the age of gene therapy, growing our own organs, being able to replace that hypothetical heart valve of yours, we are still in the dark ages when it comes to patients being sent home on IV antibiotic therapy, or OPAT. So what is OPAT? OPAT is outpatient parenteral antibiotic therapy. It's essentially where we stick a line in a patient, kind of what this looks like right here, and we send them either home or to a nursing facility to receive antibiotics for an extended period of time. Now, OPAT was initially an alternative for uninsured patients who couldn't afford to stay in the hospital very long, so we could discharge them sooner to receive treatment at home. And it didn't really gain a lot of popularity until the 1970s when we successfully treated patients with cystic fibrosis. And today it's accepted as a generally pretty good cost-saving method to discharge patients home quickly and allow them to continue antibiotic therapy. So it sounds like a pretty good deal, right? But like we talked about earlier, these patients readmit a lot. So depending on what literature you look at, every OPAT patient, about 17 to 27% of patients will readmit within 60 days. And even more concerning is that about 35% of these readmissions are due to some type of adverse drug event, which is preventable in nature with monitoring. So that leads us to 2 big questions that we have when we are researching or trying to figure out how to better OPAT. Number 1, what is the impact of this thing called an OPAT team? And then number 2, what are additional risk factors for readmissions in this patient population? And if we can answer those 2 questions, the hope is that we can improve patient outcomes on therapy. So an OPAT team is a group of medical professionals, so your physician, your pharmacist, nurse, social worker, who all will follow an OPAT patient, their laboratory values, their disease state, while they are receiving OPAT therapy. Now, not every patient or every hospital actually has an OPAT team. Could you imagine getting chemotherapy without seeing an oncologist, or having a pacemaker without seeing a cardiologist? I personally couldn't. That's just unacceptable. Yet this neglect happens all the time to these patients. And previous literature has really validated the effectiveness of these teams. So there was a study done in Bronx, New York, in which a hospital deployed their own OPAT team. And they found that patients treated by the OPAT team had increased coordination of care. So they had better follow-up appointments, they had more lab monitoring, and they had decreased readmissions while on therapy. So we've kind of answered our first question. So what about that second question? What are high risk factors for readmissions while on OPAT? Well, researchers have already looked into that as well, and they've determined that in general, the more ill a patient is, the worse they do on OPAT. So if a patient has a history of heart failure, if they're immunocompromised at baseline, if they've received a lot of OPAT in the past, they don't do as well on OPAT now. They readmit more frequently than somebody who's healthier or somebody who it's their first time on OPAT. So we've kind of answered those 2 questions, but what is the missing link? How does an OPAT team affect high-risk patients? And if you do a search of the literature like I did earlier this year, this is what you find. You don't find Elmo, but you find a big hole in the data. The question hasn't been answered. But if we can answer this question, maybe we can find a way to tailor OPAT and better the outcomes for this patient population. So that leads us to the development of our current research question, which is pretty long here. It's what's the impact of our OPAT team here at Ohio State, that hospital right across the street, on 30-day OPAT-related emergency department visits and hospitalizations in patients that are high-risk factors, that have high-risk factors with Staphylococcus aureus bacteremia. So it's a mouthful. And why did we choose Staphylococcus aureus bacteremia? Well, as most of you probably know, Staph aureus, MSSA, MRSA, MRSA is very difficult to treat. It also likes to excrete a lot of toxins that make it very virulent, so the patient is incredibly ill. It does a great job at sticking to surfaces too, so it'll stick to heart valves, it'll stick to any implanted devices. Staph aureus bacteremia is also associated with polysubstance abuse, so your IV drug users, and we have a lot of those, especially being in Ohio in the heart of the opioid epidemic. It's also very common in patients with frequent readmissions, so patients who are exposed to the healthcare setting a lot, more ill patients. And then the antibiotics that we choose for Staph aureus bacteremia are very difficult to monitor, and they have a slew of side effects that are associated with them. So all these components make this infection a very big burden for the healthcare setting, one worth improving. About $3 to $4 billion a year annually are spent on the treatment of Staph aureus infections in patients. And if I were to wager a bet, a lot of those patients probably readmit frequently within that time period. So that leads us to our current literature. So what did we look at here? We looked at all patients discharged on OPAT therapy with at least one positive Staphylococcus aureus blood culture. We assessed patients before the OPAT team was established and after the establishment of our OPAT team. Our primary outcome was, did they have a 30-day OPAT-related readmission, yes or no? So that means they came back to the hospital because, one, they had worsening infection, two, they had difficulties with that PICC line that I showed you, three, they had some type of adverse drug event, and four, they had difficulty obtaining antibiotics on discharge to where they actually had to come back into the hospital and say, hey man, I couldn't get my antibiotics, can you do something for me? Next, we looked to see if we could identify any risk factors that previous literature has identified that would lead or be associated with our primary outcome of readmission. So what are the immune status of the patient? Did the patient have any heart failure? What antibiotics were they discharged on? Where were they discharged to? We also looked at secondary outcomes. Was the patient followed up after the primary hospital visit? Did they have mortality? And so on. So when we assessed the outcomes, we found that HIV and a urinary source of bacteremia were actually associated with the 30-day outcome of OPAT-related readmissions. When we further assessed primary outcomes with our OPAT team intervention, we saw that our OPAT team did increase 2-week infectious disease follow-up, as well as coordination of care. So those patients had more frequent infectious disease follow-ups. They had more data about when their line was to be pulled, when they were able to stop antibiotics, versus the pre-OPAT period where none of that information was documented. Furthermore, we saw a decrease in length of hospital stay for those patients that were followed by the OPAT team, as well as a reduction in broad-spectrum antibiotic use in our post-OPAT group as well. So what are the conclusions of our current research project? So we concluded that Staph aureus bacteremia patients remain one of the most difficult patients to treat. So unfortunately, we did not actually see a difference or a decrease in our primary outcome of 30-day readmissions. It was pretty similar amongst both groups, which shows that even with the utilization of our OPAT team, maybe we need to expand further upon this. When you actually dive down into the patient population we looked at, many of these patients were IV drug users. So over 50% of our patients, and we screened about 300 patients had some form of polysubstance abuse. So what can we do for those patients to keep them from readmitting? Monitoring with our multidisciplinary OPAT team, though, did increase that coordination of care. So those patients had better follow-up visits. They had decreased duration of antibiotics versus the pre-OPAT team, and they also had a reduction in the use of broad-spectrum antibiotics. Next, our current OPAT team does not have an infectious disease pharmacist, so this is something that we're hoping to expand upon. An infectious disease pharmacist can assist with drug monitoring in these patients. They can also dose adjust. They can do any type of educational counseling for the patient, as well as be a participant in clinic visits for these patients. And then lastly, though we did find some associations with our primary outcome, so HIV and urinary source of bacteremia were associated with our outcome in OPAT patients, we need to continue to look at why these patients have an increased risk for readmissions. Because if we can determine why these patients are readmitting, maybe we can design and tailor OPAT therapy in the future to improve outcomes. We have tailored medication these days, tailored medicine, and we need to be tailoring our OPAT therapy as well. And with that, I will take any questions.